So my name is Don Bradley. I recently retired from Blue Cross Blue Shield of North Carolina, where I was the Chief Medical Officer and Senior Vice President for Healthcare, and spent 26 years working on the payer side of things, of healthcare and healthcare transformation. The real determinants of health and healthcare cost are really a little different than what most payers think about. Health, as opposed to health care or health insurance, is really determined by a number of factors. About 30% of it is your genetics. Only about 20% is related to the health care that you receive, and far more of it is related to your social situation, your physical environment. It's probably another 30%. And then finally, your health behaviors, which can be, depending on which author you read, 30 to 40%. And those health behaviors are in large part determined by your social and economic situation, not the 10 minutes that you spend in the office with a physician. The disconnect is that if you look at where health care expense goes, if I look at my health insurance premiums, 85% to maybe even 90% of that health insurance premium is going to medical care costs. About 5% of those people will account for 50% of those costs. 80% of the costs are really utilized by 20% of the people. So there's a real consolidation of those costs. There's a disconnect there. We're spending the money and looking at the medical care system when the real determinants of health are happening outside of the office, outside of the clinic, in the community, based on the behaviors, health behaviors that people have. And although payers and clinicians both work to change behaviors, and rightfully so, and with best intent, the real impact comes from where you live 8 hours a day, what your family looks like. Is it safe to walk outside? Are you exposed to fungus that exacerbates your asthma? So the real determinants of health, I think, occur outside of our typical healthcare system. The other piece of that is that we know that 75% of healthcare costs occur with chronic conditions. And if you take that back up to what the determinants of health are, we're really missing the boat. Chronic conditions really demand a different way of managing care than the acute care system that our healthcare system provides currently. So the Practical Playbook does a couple of things from a payer perspective. One is that it helps to define what population health means. Again, I think there's a lot of misunderstanding of what population health means. And it really is to take a group of people and see what their health outcomes are, but also what the distribution of those health outcomes are and what the interventions are that impact those. So one is just understanding what population health means, and that's particularly important in an era now of value-based payment for services and the intent to really pay both healthcare providers and the payers based on outcomes of populations. So it really gets to be, okay, what are we talking about? Why is that important? The other thing that's in the playbook is, how do you work together? So payers or health insurance companies have typically worked some with providers, but if a lot of the determinants of health are really outside the provider community, how does one really get out and work with the places, the community organizations, the public health department, to really have an impact in a much broader space, especially if you're really, as a payer, being held accountable for what happens every place, not just in the small arena that you really play. The third piece of the playbook that I think is helpful to payers is to move from what is it that we need to do to actually how do we get it done. I think it's always wonderful to sit around and say, well, we really need to do this or that. And then you kind of hand it off to somebody else. It's How do you get that done? Who do you talk to? What kind of data resources are you going to use? And to really begin to move from kind of, okay, I get the vision, but how do I actually implement it? I do think that payers sometimes worry about competitive advantage. You know, what I'm trying to do is to sell my health insurance. If I help the entire population, how does that really help me as a payer? Well, this is where that goodwill of helping, first of all, I think there's enough churn in health insurance, especially now with the exchanges of the marketplace, that you may not have a member now, they may go someplace else, but they'll be back. And wouldn't you rather deal with someone who's been healthier because of an activity? I think the other area, and it's almost a source of funding, is look at your marketing resources for the payer. You know, there are activities like bicycle share programs that we did at Blue Cross Blue Shield, or community gardens or playgrounds. Those are population health initiatives that, one, require some sort of collaboration or integration with the community so that you're putting them in the right place and getting the right help, but they also create a good deal of goodwill for both the marketplace and then the people that are specifically being helped with that program. And finally, let's not forget the public health departments. The public health departments provide a vast number of services, many of which we're not really aware of. You know, I was looking at the 10 essential services of a public health department, and it includes kind of monitoring health, which would be important, and in fact, the public health department oftentimes has data that a payer or even a health system is not going to have. It includes helping to write and develop policies to help the broader population. And finally, it helps to assure that things are actually being done. So the public health department is really a unique and valuable resource that we have underutilized. And it doesn't have to cost money. Now, you may want to share and collaborate and share some expenses there, but it really is incredibly useful.